All right, so this is the next video for medications that we will be covering for the musculoskeletal system. And it's basically medications for rheumatic disorders. Some of it's a review from when we did the analgesics, but others not so much. And I want to talk about the term gold, just like gold that we wear, GOLD. They're gold compounds. They're used to treat rheumatoid arthritis, and juvenile rheumatoid arthritis. Works best in the early stages of arthritis. It takes 2 to 6 months to work, does not cure, but it just manages, and they are called gold compounds. They're injected into muscles or taken orally, but the oral ones are going to be less effective. It's better if they're injected into the muscle. Side effects, they can have a metallic taste in their mouth, thinning hair and rashes, and they also can have sores in their mouth and diarrhea. But it does really, really help with pain in early stages of arthritis. Drugs for rheumatoid arthritis and gout, autoimmune inflammatory disorder. So to treat it, we need to relieve the symptoms, basically, maintain joint function, minimize systemic involvement, and delay the progression of the disease. Because again, it's autoimmune. We don't know why the body has decided to attack that synovial fluid. And here is the same picture that I have showed in the musculoskeletal dysfunction PowerPoint, where you see the bone, the articular cartilage that is just standing up there and looks exactly like it's supposed to, synovial cavity. And then with this disease, the joint degeneration begins with inflammation of that synovial membrane. Then we have that pannus formation, which starts the erosion of the cartilage until there is no more cartilage, and we've got bone fusing, bone on bone, and that's why the severe pain. So classes of anti-arthritic drugs are going to be our NSAIDs, because it's massive. They're the best anti-inflammatories we have, aside from glucocorticoids, and they have a lot less side effects than the glucocorticoids. So we're going to start with NSAIDs always. And they're also going to start with somebody who's got RA with DMARDs, our disease-modifying anti-rheumatic drugs. And the reason they need to start with that is because it takes a while to maintain a blood level of these drugs. So that's why I have it capitalized. Start with DMARDs now. And glucocorticoids may be added until the DMARDs work, because again, it can take 2 to 6 months for them to work. So in summary, our NSAIDs provide rapid relief of symptoms but do not prevent joint damage and do not slow the disease progression down. Does not do that, but it does have rapid relief of the pain. The DMARDs reduce joint destruction and slow the disease progression. So that's why we have to start them immediately. Happens much, much slower than the NSAIDs, but it does slow the disease progression, because it's modifying that disease. It's slowing it down. And then glucocorticoids provide rapid relief of symptoms also, and they can also slow the disease progression, but they have serious toxicities, such as they can make you diabetic, they can cause bleeding. So glucocorticoids we're not going to use right away. New way to think is that we start aggressively to slow the disease process down. So we start within 3 months of the diagnosis of RA for most patients, may be able to arrest the disease process with this group of drugs. And they used to just give them one at a time and very slow. And then they decided, no, the pannus formation was going on no matter what, and the bone on bone was going to reach. And that's when it's very, very hard to get rid of that pain. So now they start with NSAIDs, and DMARDs are going to start at the same time because it takes a while to work. And then the glucocorticoids will be added right away with the NSAIDs until the DMARDs work. And we also have the adrenocorticosteroids that is umbrellaed under our glucocorticoids. Methotrexate, our Rheumatrex, is our most rapid-acting DMARD. It's been around for a long time. You may remember it from our cancer section, where it's a very, very good anti-neoplastic, but it also is a very good DMARD. Therapeutic effect is in about 3 to 6 weeks. Again, it takes a while. Adverse effects, just like a lot of our chemotherapeutics, are bone marrow suppression and our GI ulceration. but it also causes hepatic fibrosis and pneumonitis. So with this drug, we have to monitor liver function tests, obviously, liver enzymes, advise the client to look for signs of liver toxicity, such as jaundice, abdominal swelling or abdominal fullness, having a paracentesis type, a lot of fluid in the abdomen. Bone marrow, we're going to obtain a baseline CBC and platelet counts and follow closely because we know what this drug can do. It's going to drop all those counts down. GI, we're going to take with food. Prophylactic use of H2 antagonists such as ranitidine, just to keep the acid down. And what does ranitidine do? It suppresses the secretion of gastric acid. So a lot goes on for them to be able to take this drug, but we also know that it's very fast acting and it's going to help this disease process. And then we have Enbrel, which is one of the newer DMARDs. It inactivates the TNF, or the tumor necrosis factor, and that suppresses inflammation. And this is one of the big factors in rheumatoid arthritis. So use in moderate to severe RA, so we're not going to be using Enbrel right away. Adverse effect, they can get infection and injection site reaction. Again, just to go back to talk about TNF for a minute, it's an important factor in RA pathophysiology. It binds with receptors on the cells, excuse me, in the synovium, thereby stimulating production of chemotactic factors and endothelial adhesion molecules. And what this does, it promotes infiltration of neutrophils and macrophages. So the result is extreme inflammation and joint destruction because it doesn't go away. It just sits in there and erodes. Okay, and finally we'll talk about gout, which is a recurrent inflammatory disorder, basically hyperuricemia, where we have uric acid in the blood. Episodes of severe joint pain causes, again, excessive production of uric acid or impaired renal excretion of uric acid. So with somebody in renal failure, do you suppose we have to watch those uric acid levels? Absolutely. Drug therapy for gout is going to be glucocorticoids. Again, it's an extremely inflammatory disorder. We would be using those for inflammation. NSAIDs for inflammation. Colchicine and indocin decrease inflammation in clients with gout by possibly preventing infiltration of leukocytes. These medications, the first two, colchicine and indocin, do not affect uric acid production or excretion. Both of these are given in the treatment of acute gout attacks. They also decrease the incidence of acute attacks for clients with chronic gout. Then we have our allopurinol or azilipram inhibits uric acid production, and probenecid or Benamid inhibits uric acid resorption by the renal tubules. Allopurinol and probenecid are given for hyperuricemia, chronic gout secondary to cancer, chemotherapy, because those two are going to lower the uric acid levels. Need to take all of these with food and provide antidiarrheal agents as necessary. We'll use colchicine cautiously in older adults and clients with renal or cardiac problems. Glucocorticoids, highly effective for relieving an acute gouty attack. NSAIDs are usually preferred just because not as many side effects. Colchicine is an anti-inflammatory, only use in gout, works by inhibiting leukocyte infiltration. There is no phagocytosis of uric acid and no subsequent release of lysosomal enzymes. Uses treat an acute gout, reduces incidence of attack, abort an impending attack so it can ward it off. Adverse attack, it's going to be GI, nausea, vomiting, diarrhea, and abdominal pain. And then our allopurinol or azilipram reduces uric acid level in the blood, which inhibits that xanthine oxidase, an enzyme required for uric acid formation, and that's how it does reduce it. Uses in chronic tophaceous gout and hyperuricemia due to chemotherapy, which is going to be breaking up a bunch of cells, leading to uric acid floating around in the blood. Adverse effects are pretty well tolerated, GI and some neurologic. And tophaceous gout is, all that means is the tophi are hard nodules around fingers, elbows, and around the big toe. Can appear anywhere in the body. But tophaceous is usually chronic gout. Used synonymously with tophaceous is chronic. Okay, that's the end of our videos on for medication anyway for musculoskeletal. Hope you're having a great day. Bye-bye.